So this session is the session on biosafety in food security, ensuring national security through resilient food systems. And I can't think of anything more timely or more important to think about than resilient food systems, which is what's going on in the world. So with that, I'm going to turn it over to Ambassador Dr. Deborah Birx, who's on our board, and she has been phenomenal and supportive all the way from China to Saudi to New York, and I don't know what we'd do without her, but I'm glad we have her. So Dr. Birx, it's all yours.
Thank you. Really great to have you all back. So my poor panel, we had a pre-discussion, but I'm warning you, we've changed everything. Because I thought we should include what we talked about this morning, because I was so impressed with what we heard. So I heard that bold leadership that empowers the people who are closest to the issue is the best way for success. So I think hearing that from General Petraeus and how President Bush supported him, having worked on what is called PEPFAR for President Bush, I know that he just has high expectations, and as he's given you a task, he just expects you to accomplish it. So it's that kind of empowerment really leads to incredible potential in your staff. We also heard that the world of healthcare is going through a lot of innovations and really bringing 21st century technology. And you've heard from the panel that in certain areas, there's fearless investors supporting fearless CEOs. But this panel is going to be something different, which is always hard for me to say, but we did have an extraordinarily impactful pandemic. We knew where, and we know now clearly where all the gaps were. And here we are 5 years later, and I can tell you that 99% of those gaps have not been addressed. Because as opposed to fearless investors, we have very fearful bureaucracies that are still mired in 20th century solutions. And so this panel, which was handpicked, are quite extraordinary because they all have brought fearlessness to innovations that are truly needed that many of our governments don't know they need. And we're going to talk about why that is and what can we do to change that. So we have Philip Mervis from Biosafe, who's really invented 21st century technology to change how we handle sick animals in sick areas, which is obviously really key to our food security. We have Michael Mina, who I got to know during COVID, who has pushed the envelope on diagnostics, because the other thing that I heard this morning from the Alzheimer's talk was we have to find people before they have organ damage. Well, that's the same principle in a pandemic. You have to find people who don't have symptoms, because believe it or not, or the cow that doesn't have symptoms, or the pig that doesn't have symptoms, or the chicken doesn't have symptoms, because if you wait for the chicken, the cow, or the human to have symptoms, it's spread through the community. It's too late. So you have to test, and he's really starting a whole new center at MIT, really focused on 21st century solutions. I pray that you're successful so that we can get ahead. And Dr. Wiebe, who from North Dakota, where I met that team during COVID, that team, and I want to be clear, every governor was dedicated to its state's population. And the reason I went to 44 states is because they knew the culture, they knew the communities, and they knew how to word guidance so that it could be implemented. Because it doesn't help us to have a national federal institution put out guidance that cannot be implemented successfully. What do I mean by that? Well, when you put out guidance that students have to be 6 feet apart and you have to open windows in order to have safe indoor air, and you're in North Dakota where it's minus 30. When I said that to them, they laughed at me. They're like, Yeah, this isn't the East Coast. This isn't Washington, D.C. We don't crack our windows in North Dakota. So if you put out guidance that schools cannot do, they close. And we have not fixed one guidance for schools for aerosolized viruses to date. Those same things, 6 feet, which had nothing to do with anything because it wasn't primarily droplet, all of those things have not been modified. It's 5 years later. And so people like Dr. Wiebe were at the front lines of creating local guidance that could be implemented. And I just want to make it clear, half of our states or more fully opened their community colleges, their K through 12, and their upper higher education in the fall of 2020 without problems. How did they do that? By practical guidance that could be implemented, like 21st century testing. So remember last time, our idea of screening people, for those of you who came into the United States during the 2020 before the borders were closed, syndromic. Call us if you get symptoms. We probably left in 90% of the people who were infected with COVID, and people wonder why their COVID spread so rapidly to every major city in the United States, east of the Mississippi. It's because we let them all in and said, just call us if you have symptoms. We have to move to 21st century. Even Africa, where I worked for 25 years, knows that you don't diagnose HIV, TB, and malaria by symptoms. Everybody has fever. You do a diagnostic test. But we still, to this day, on our federal websites, have influenza-like syndrome. That's what we're tracking still on the human side. So, unfortunately, that's what we tracked in animals, too. We waited for the dairy herds to develop symptoms. So, team, enlighten us with all of this stuff that we discussed, why we are still using 20th century technology in the 21st century world. Start with you, Phil.
I think
What's our problem?
our problem is that, I go back to the old saying, you can't get fired from a railroad unless you make a decision. And that is the problem in government, is that the government is, in one sense, the last insurer of public health. And if the government isn't prepared, if the government doesn't make a big enough investment, and that's not just money, it's both people and systems and surveillance, as you talk about. And you can think about COVID, but it's the same scenario in animal health. It's the same surveillance, different organism, same surveillance. And the damage is just as great. If we were to get some large outbreak in the animal population, meat prices go crazy, and the farmers go broke. And food security is national security. And if you haven't realized that, I believe it's Genesis number 41 where they talk about, I mean, it's an old problem, right? And China has, I think, 15.
You mean manna's not going to come down from heaven?
And the Chinese know that. They have 15 billion pounds of pork bellies put away because they fear that. And they, for all I know, they have a better surveillance program than we do. But we need government and private investment in systems to handle outbreaks and to head them off. And it starts by heading them off, but it also has to have equipment to take care of them when they happen, because there's going to be a disease. We don't control that. And if you look at the MENA region, they have concentrated agriculture. We're lucky in this country. If we get an outbreak in Delaware, we still have California. But if you have concentrated agriculture, like the dairy farms in Qatar, that's a big deal for them. They're a net importer. The Gulf regions could be net importers of food. They don't have that luxury. So their biosurveillance and their treatment and systems to take care of this should be even stronger. And we believe that at Biosafe that our systems, we take down any pathogen, animals, humans, wastewater, medical waste. It's all possible, but there has to be a better plan. And getting the government to get involved with private industry. I believe that this government should not be paying for every chicken to get killed. It should be, the chicken industry should help be part of that, and they should be part of the solution.
Well, we know public policy will drive amazing private sector innovation. So, Michael, talk to me about how you see where you think those gaps still are, why you went to MIT, and how you're going to fix it for us.
Yeah, it's a great question.
High expectations from you.
I think to the first question, I think in part it's a lack of imagination. We have an extraordinarily fragmented system in the U.S. that doesn't exactly, there's no financial incentive really kind of across the board to actually innovate in things that are proactive health, preemptive health, public health, whatever it might be, biosurveillance and security. We've not really had really bad ailments in the United States in a way that so much of the rest of the world has had. I remember when the pandemic started, I was saying to some media outlet, like, we're not ready for this, not because we couldn't be, but because we've been in a very luxurious state for so long, as the United States anyway, that I used to say people don't even know what bad looks like, because the reality is, as a country, we've done so well for so many decades that I don't think we could see that there was actually a problem on our doorstep until we were literally inside of it. And I think that stifles innovation for sure. But there's also there's very limited investment because of the social structures and context that we've created over decades. Since the mid-1900s, the late 1800s and early 1900s, there was actually a lot of investment in public health. It actually made people money. As things shifted and CMS took over and we had medical, which I now call sort of sick care reimbursements, kind of go through the roof, everything, the whole innovation pipeline shifted to sick care and medicine, which, that is what it is. It's great to get people who are sick better, but it also meant a near total abandonment of how to even contemplate making money off of keeping people healthy in the first place, to the point today where it's now just dogma that you can't make money off of keeping people healthy, which I think is crazy. We should be able to. And so I think what it sort of needs, it needs companies to get started who are doing things that keep people healthy, that are also revenue generating, profit generating companies, but also takes a new talent pipeline of people. So that's why at MIT we're creating this new center, which is dedicated specifically to create a new field, which I call public health or population health engineering. And we're doing it specifically in the business school, not at the engineering school, not at any sort of school of public health that's going to vilify making money. Do it in the business school. Encourage people to go into public health and make a lot of money.
Yeah.
Why should that be a bad thing? So we're trying to create a new talent pipeline and a new entrepreneurial spirit around things and change a new ecosystem, and also build the financial and economic models that make it make sense. Because right now they are completely upside down, and of course we have no innovation.
But I think there were governors, like Governor Burgum, that really saw that there was value to having a healthy workforce and kids in school so parents could work. Talk about, what you all did that was outside of the box, and why and how he allowed you to innovate.
Yeah. As a matter of fact, I was so fortunate because when I moved to North Dakota to work for Governor Burgum, I had to research Governor Burgum, and then I learned about his entrepreneurial, he started a business 20 years in the year 2000 in software business, and then he grew it to kind of a multi-million-dollar company. And that was one of the things when I kind of moved to Bismarck and started interacting with the governor. He understands business. He understands how to make decisions based on data. And I told him, well, hey, I'm also a data-based individual, and that's how good science works. You look at the data and you make decisions. I think also one additional feature of the governor is that he wasn't shy of making decisions that are different from the usual government politics because of his business background. So one thing that we started doing is we started collecting data and making this data available for the public and for anyone, so then they can make also their decisions based on the data. So every few months we were kind of like, launching new dashboards, something about vaccines and about symptoms and about the, testing. But then also one other thing, thanks for mentioning that, the culture and the climate even in North Dakota is different from the East Coast or the West or the South. And this has its role in making decisions, because part of public health and being in government is you have to provide the advice or recommendations for your citizens so then they can follow it, rather than to make it so impossible that they dismiss your recommendations. So the state was in charge of all the testing because none of the other hospitals or healthcare systems wanted to take that ownership. So we were getting all the machines and running all the PCR testing. And then we got to the point that, okay, we should not look at averages, because not all the state is the same. So we have a more populated eastern part of the state, but as you move to the western part of the state, it's sparsely populated. So when we are basing our decision based on the average or based on the highly populated areas, we are kind of like, it's unfair for the rest of the state. So we started kind of instilling that local-based decision-making process based on the data. So our dashboards could be kind of drilled down based on counties, based on kind of like different regions. And we were telling, the local public health departments and all other citizens, all the citizens in the state, is that, well, you should be able to make your own decision also. What helped with that is the self-tests, those testing that were available, individual testing. And luckily, and kind of that was intentional and strategic, we decided to purchase 2 million tests and make them available for the whole state. And the state purchased those tests, made them available.
They have about 850,000 people in North Dakota, yeah.
Yes,
So 2 million tests is a lot.
Yes, so.
I thought I should explain that.
Yes, and like the governor facilitated that process, but I made the decision, let's get 2 million, because it was a one shot in maybe 2 years that we were able to access and purchase the tests, because all the tests were back ordered, and they tell you, well, it might be available in 6 months or 10 months or whatever. And we were able to kind of pay for the test and get them in a matter of few weeks. We made them available free of charge across the whole state. Even you go to grocery stores and pick up these tests. And that was intentional, because we told them, well, here are the tests. You go do your own test and make your own decision. Here are our guidelines. You can quarantine if that is possible. If you are living by yourself in your house, then that's a quarantine by itself. But I think one thing about public health and about government is that people do not like getting orders or the government to make a decision on their behalf. So our strategy was to empower our citizens. Here are the tools, here's the data, here are the tests, make your own decision. This is our guideline, but it's not an order, it's not a decision, it's like for you, so then you make a better decision for yourself, for your children, for your loved ones.
Great. So we're going to turn back to you, Philip, because let's talk a little bit about avian flu. And I think most of you, and I'll have you talk about how we just kill massive numbers of chickens every time, because that's a 19th century 19th century solution to what you do about animal care. So let's talk about a little bit about avian flu. And what many of you may not realize that 95 or 100% of the herds of California got infected. So these are our dairy herds, and of course, no one's going to kill all the dairy herds, or you're not going to have milk. And so they had most of them symptomatic, or some testing was done. But dairy workers have to be intimately involved with the dairy herds, as opposed to poultry workers that can have more of a distance. And so if we ever wanted to know what really is the transmission rate between dairy herds and the workers, we should have anonymously provided tests to each of these some of them are large conglomerates, so they can anonymously test their workers so we could find what the asymptomatic transmission is. When they finally did that was in some vets, I think they were in Wisconsin or Indiana, they found about 5% of the vets were infected. Well, 5% of the vets are infected that are only occasionally exposed to that cow. What do you think the dairy worker percent was? But we don't know because we didn't measure it. So when people say they're following the science and the data and they don't get either, we're not following the science and the data. We're choosing to put our head in the sand and pretend that it's best not to know. So if you guys want to understand vaccine decision making, go to the Green Book that the UK puts out. Just put in your browser, Green Book, COVID-19 vaccine. You'll find the best analysis of who should get the COVID vaccine, why they've made those choices. And by the way, they tested all their kindergartners and found they all had antibodies, so they stopped immunizing under 5 in 2022. So they got the data, and then they made a decision. We didn't get the data, we just made a decision. And so I really think when you talk about population health and public health, and people talk about accountability, it's really about what Dr. Wiebe just said. It's about transparency and transparency in the data. And the reason we don't have transparency in the data is because it's not comprehensive, and you'd be appalled at what partial data sets people are making decisions on in the 21st century, where we could have full data sets. So talk a little bit about avian flu. You know the poultry industry well. Why aren't we testing, now that you can do pooled DNA tests, why aren't we testing animals early and then just pulling out the infected ones using your technology?
Maybe they don't want to know. I mean, to a large extent, people don't test because they don't want to know, because if they found something, it would change the economic model.
What if it didn't, though, because you were only removing the infected ones?
And that's the question, and I don't have a good answer for that because I'm not in, my company is in the equipment to solve the infected problem, not necessarily to sort through the herd. There are other people, there are members of, in the
right, but if
from,
your solution was there,
I think
that guy could quietly test his chickens.
And if
he doesn't have to report it. He could test his chickens, dispose of his chickens in a safe way.
Absolutely. 14 years ago, I sat with the head vet of the USDA, described our technology, and his answer was, I want it on the back of every chicken house. Because Americans most people are disconnected from where their food comes from. In a chicken house, there's mortality every day. And in an avian flu outbreak, there's more mortality, or in the testing, you should test what's there and dispose of the ones that are. The worst thing you can do is haul that stuff off the site. You need on-site treatment.
Yeah.
And so, especially in a concentrated food environment of 1 million chicken house, destroying 1 million chickens because 1 or 2 comes up sick is kind of insane. But what's the current policy? And it shouldn't be the policy. If we could do the testing and we could get the data that what was predicted, we should be able to selectively cull.
So
which
what
would save the government money.
Yes, but what keeps Tyson's or Purdue, a private sector group, from working with you directly to try a new technology?
Nothing except inertia. I think there's a lot of inertia in the government, as you say. There's inertia in the large private corporations. They don't want to rock the boat because they're multinationals and there's a lot of politics in ag. It's unbelievable. I mean, there's a lot of politics in ag. I was sitting with the ag attaché.
There's no politics in humans.
No, I know that. I was sitting with the ag attaché from Australia. And this is 10 or 14 years ago. And there had been a foot and mouth outbreak in Korea. And they had popped and dropped 2 million hogs. And we were speaking with the Australians. He said, well, I understand you had custom agents that got caught getting bribed to bring in South Korean pork. What would that have meant to your economy? He said, if we had foot and mouth in Australia, it would have been $15 billion the first day before our friends piled on, which means they would have lost their export markets. Yeah. And so a lot of this is about what our, quote, friends or partners will accept. And maybe what is accepted from our export partners is kill the whole house.
But if you were testing, you could say that my birds, my eggs, my everything.
I agree.
People are paying a premium right now for, people say to me all the time, this whole thing about food additives. People are willing to pay extra so their dogs have food without additives.
Yeah. Okay,
so why are we acting like the consumer won't pay 50 cents more to have food without additives? I don't know if you watched what happened with Cheetos, but the minute they said get rid of the artificial dye, within a week, they had Doritos and Cheetos and everything.
That's because they were prepared because the Europeans
required it.
Yes, exactly. I mean, there's lots of lessons from around the world, and we need to be listening to them, like the British study. But some of the stuff that comes out of Europe, you sort through it, you decide what's really good, and you should, or around the country, the stuff coming out of the MENA region. There's good ideas there. We shouldn't be so chauvinist about it. And I'm sure that Dr. Mina has situations just like that in vaccines.
So, Michael, what are you going to do? What are you going to do to get the private? Because I love this economic model, because when I went to some of my colleagues about, I'll be honest, when I was out in the field, by the way, get gas if you get in North Dakota, because most of the exits are only for ranches. When he says sparsely populated, he means it. Get gas in Fargo or something, because there is no gas. And I'm like,
with the grates as you get off, so the cows
you're on this interstate, and I'm like, oh, look, there's an exit. It's going to I'm like, oh, these exits are for ranches, not for amenities and hospitality. So it's a totally different thing. But how do we because I think if the private sector, if you could convince Purdue, let's just say in Delaware, not even their whole company, to say, give me 6 months to show you that this model saves you in the end a couple $1 million a year, probably the private sector or more would do this. Because I'm getting a little frustrated that our public sector is not going to change, because for those of you who are concerned, we're no better off than we were in 2020. We don't have the data, we don't have, but now we have a population that doesn't believe any of us. So yes, we are worse off. So Michael, how come MIT, how are you going to monetize this? Because that's what people say to me all the time when I say we have to do something about rural health care. They turn to me and say, how are you going to monetize it?
Yeah, I think on the one hand, so first of all, bringing in economists and doing public health in a business school is number one.
Yeah.
Get people who understand the market, who understand the business, to get into public health. Get engineers to get into public health. Don't try to do it the other way around, because it just continues the status quo. And so that's number one. I think I'm starting it with the most recent Nobel Prize winner in economics, because he did all of his work in the past on understanding why institutions succeed from an economics view. And so, I think that's number one. There has to be money. There has to be money to be made, and that might actually require changing the way we think, or the way we are allowed to budget things and model things. We have very strict ways of how we structure our budget.
So you think you can convince venture capitalists to invest in this new model so that you can be a unicorn? Unicorn in public health?
No, there's great examples, like in the area right now. So GLP-1s are a really good example. They've been brought up today. The Ozempics and whatnot. This is the first time, this is actually in the chronic health space, this is the first time preemptive public health anything has been massively sexy and successful. People want to pay ridiculous amounts of money for it.
This, because he started it and said exactly the right time. So you're going to make us make up for everybody that came in late? 15 minutes late? We started 15 minutes late. I don't.
No, I wanted you to take 20, so take 10.
You're giving me more time? Oh, I think I heard more time.
But
I
so GLP-1s are a good example today of where all of a sudden we have the private sector has to figure out how to. The private sector is effectively paying, at least in the U.S., 50% of all working adults. They're paying for the public health of working adults now, employers. So how do we now accommodate and account for all these people who want to be on these very, very expensive medicines? Well, our normal budgeting just makes it look like a massive cost. So HRs, groups around from the biggest companies out there saying, well, we don't want to cover it. And begrudgingly, they'll cover it on, and you have all this PBM crap that's happening. Instead, you can just, if you can take a longer arc and you can start actually building out the economic models in such a bulletproof way that say, look, if we start funding everyone to get on these medications, regardless, like I'm just using this as an example, people have all different views of it, but if we start doing it and it's going to save the whole ecosystem billions and billions and billions of dollars in the next 8, 10, 12 years, it's hard to justify with our current quarterly approach. Mm-hmm. But if we can start building out a mode of thinking in the economics and business and budgeting world, whether it's for public or non-public companies, I think that's how you start doing it. But we have to start enabling investors to be able to look at a longer arc in order to do it.
Or you get a state that has pretty significant underlying
getting back
conditions
into the public sector for sure.
And get them to do it as a public-private partnership.
That's exactly what Medicaid is now doing, because Medicaid's the one, Medicaid and Medicare, they're the ones who everyone's going to graduate to. So they're the most incentivized to figure this out now. And so they're starting to do pilots to just ask the question, should we be covering weight loss medication? And they're going to find that, holy crap, it's going to save us massive amounts of money at the same time that we're having this deluge of older people joining Medicare. And it's actually going to save money if we start spending the money now. It's hard to...
So Dr. Webby, you've gone to a university, let's just say, that closed during COVID and did not open. Ooh, so change starts at home. What are you going to do to change things there?
Well, and again, I mean, we have to ground everything on data. But then, so one thing that is kind of like...
Is Rutgers showing how to be resilient and stay open next time?
Possibly. It depends on what kind of pandemic we are going to get. We know that we are going to get another pandemic. We do not know what and how and when.
I think we can make an assumption that it could be aerosolized virus, and perhaps we should be ready.
Most likely. And that's the thing, is like, one thing about preparedness as well as public health is you have to kind of have the vision 20 and 30 years down the line. And that's one of the reasons why public health is not really sexy and attractive. I mean, we all gravitate towards acute healthcare because it's kind of like the instant gratification.
I find it very sexy to work in public health.
Yes, I mean, only for the very few who know the value of public health, but it is an investment. It is an investment that pays dividends in 30 years and in 40 years. And we have to have this kind of long-term strategic planning and the ability to understand that it is an investment. Because, whether it's covering the GLP or other emergency preparedness, that's all investment that will pay dividends in down the line. And if we do not invest and we miss that opportunity, then in 30 and 40 years we will have more obese people and more chronic disease, as well as like more Alzheimer's. And then that's maybe the golden time, the opportune time to start investing and recognizing that public health is not just kind of something that will be done overnight.
And understanding animal health and how important it is to change our model. So I want to take 3 quick questions from the audience to see if you stayed awake. Dr. Mann, then these 2 right back here. So 1 here and these 2 that are right in my line of sight, sorry, to my right. Dr. Mann.
Michael, thank you. This question is for Michael. When you're talking about the larger arc and how we can make contribution from the private sector, perhaps, where is the role of the individual, and maybe there should be incentivized, maybe a half-price drug so that, because the notion that the whole society will benefit is not good enough for the investor or the private company that's going to pay for this medication, and that employee is either going to be on Medicare someday or going to go to a competitor. So that notion doesn't work very well, at least from my perspective.
Okay, we're going to take these other two questions quickly, and then we'll answer them. I think it was someone right in the back row, sorry. Yes. And do we have one more?
Hi, thank you.
Perfect.
I've been working at the intersection of policy and public health, and more recently since COVID actually, in innovation and access to care, because we partnered with emergency use rapid test kits, and then we put them in parallel with what the school system was doing, right? So they would test on Thursdays, so we test on Mondays, just to make sure that there's less spread of the disease. And I completely applaud what you said. We still have no policy on aerosols. And I know this is focusing on infectious diseases, but also what we need to think about is non-communicable diseases as a public health crisis.
Yes, and it is.
What can we do up front now, like you mentioned, about health economics, to tell the payer system, to tell other people that what we're doing now is going to cost us millions and billions of dollars savings 20 years from now. So I just want to know how to convince people to do that.
Okay, and right
Thank you.
back here. And then we'll go down the line for anything you want to end with, and then I'm going to end with a public health message.
Great, thank you all so much. I'm your friendly neighborhood Brit, so cheers for the shout out to Green Book. I really appreciate it. That being said, even Green Book is a very flawed resource, and part of that is because of the way in which we're collecting data and then reporting data. It's still overly aggregated. Even in the UK, where everything's centralized, we don't have the ability or the resolution to actually report really specific sub-trends of impact, which can be clinically critical. My question is, how do we ensure that we don't fall into tech will fix it complacency, where it's just somehow we're going to add to the noise and AI will streamline everything and pick out the perfect precision medicine system? Who is motivated to pay for data harmonization and these, be it One Health efforts, to really get the best out of the data possible?
She makes a remarkable point, because if you don't collect data in a disaggregated way, you don't find the positive deviance. And that's where the solutions are. You know how we heard innovation happens on the ground? I have found that all over the world. There's innovations on the ground, and you miss it if you have the tyranny of averages. And so I think you make such an important point. Okay, we're going to go down the panel for last words and answer.
First.
Okay, Michael, we're starting with you.
So the question, what's the role of the individual? I think, in these systems, I think the individuals, public health and our societies are just made up of individuals. So I say this with COVID and COVID testing, and when we were just getting started with that in early 2020, and then with GLP-1s and such, I think the individual has to pull their own weight, but that's kind of like, public health will not work. Society won't work if the individuals aren't pulling their own weight in the first place. And I think, whether that means they're putting in some of their own capital to get their GLP-1s at this point. Hopefully it ends up with a healthier populace later on. I do think that's part of it. In COVID, it was give everyone rapid tests. That was, my biggest thing in February of 2020. Get them out into the world. And don't worry about the top-down public health approach. Let them each play their own little part. Whether that's I'm not going to go to church, I'm not going to go to the grocery store because I'm positive. They don't necessarily have to not go to work for 8 days. Just do what they can, and it does pay dividends, I think, but there is there's a communal component that's at least not built into the United States fabric, I would say, where pull yourself up from your bootstraps, so it's a little bit hard to push that message, but I think at the end of the day, people do it. It just, I think the most important thing is to get the tools out to them to be able to, so in this case, whether it's helping people afford $1,200 GLP-1s, the best thing we could do is just shut down the PBMs. That would cut half of the cost off. But we don't do it. Maybe government should, get more involved from that perspective, I would say.
Great.
Yeah, so a couple items that I'll talk about. One is data and one is private businesses. So we talk about data, and I think the way to go about data is through the private industry, because so governments are kind of like, they collect, if any, of the data. It is like in ancient forms and ancient aggregates. But when I moved to North Dakota, I realized that some of the data, it was in the Medicaid division, that is still housed in mainframe. And then they've been kind of like contracting some companies from Latvia to transfer it to something that is maybe readable, and move it from like the 70s to the 90s. And then governments move like the Titanic. So it will take forever for them to kind of maybe even be up to date. And that is kind of like, essentially, it's a policy issue, because legislators, when you go and ask them for money to invest in IT, in technology and data and so on, they do not see the
We need
value.
you to wrap it up so we can
Okay.
move to Phil.
They do not see the value. The other thing is private businesses, when they recognize that having a healthy employee community, that will allow them to invest more in public health and preventative care and cover the GLP medications, that will allow them to have a healthier employee and better production and more financial prominence.
Great. Phil.
I think from the investor point of view, we talk about timelines that are 10, 20, 30 years. No investor wants to talk about a timeline that's over 3. Let's be honest. So there has to be a public-private partnership to get innovation in. There has to be government incentives, whether they be rules, testing, data, some form of, hey, I want to work with you where you get the data. And then the other component to that is vote. Literally, be an active citizen. If you want government to change, get on the phone, write your congressman, your representative, if you're in a different country, your person in your writing in England, get on, be an active citizen, demand better, demand these things, and then you get change. And if you don't, we'll just be up here screaming for the next time.
So I want to wrap this up, and I really want to thank the amazing panel, because each of these have been pushing a very big rock up the hill to save you and to save the food industry in this country, despite people telling me they don't need it. Fine, I wanted to leave you with a positive story. So I know many of you have heard about the measles outbreak in Texas. Believe it or not, it is a positive story. I've tracked it every day because I'm working in West Texas, working on an alternative model of rural health care. That outbreak was in Gaines County in a Mennonite community that had never been vaccinated. We have religious exemptions that go back decades. Amish, Mennonite, Hasidic Jews, same kind of outbreak that was here in 2019 with measles. A third of those cases were in adults because no one in that community was immunized. But every county and their attack rate was about 3 per 100 that we knew about, but we weren't testing. So in the surrounding counties, where the childhood vaccination rates were 95%, in all of those surrounding counties, their attack rates were 1,000-fold less. And the story should have been, parents, thank you for immunizing your children, because what started in Gaines County in an unvaccinated cohort did not spread significantly into these other counties because of the high vaccination rate about children. Instead, it became a very different story. And so now everybody is frustrated again and questioning childhood vaccines. But it really is a positive public health story that every county that was surrounding Gaines County has been protected. And so we turn these things into political talking points that don't represent the data or what's happening on the ground. And that has a huge impact on all of those counties in Texas who did an amazing job, those parents getting their children immunized. So there are very positive stories out there. If you dig underneath, childhood vaccines are effective. They do create herd immunity, protect your child and the others. COVID vaccines do not create herd immunity, and so it shouldn't have been mandated, but it was. So now we've got to dig ourselves out of that hole because people are very mad at public health officials for doing that. So thank you for your attention post-lunch. Everybody stayed awake. I kept my eye open. And thank you for giving us a minute or two extra.